go ahead and get started. Hello, everyone. Thank you for joining the Center for Learning Health System Sciences for our monthly impact seminar. Before we get started, I'd like to cover a few expectations. Today's seminar will be recorded. You can enable closed captioning by hitting the Show Captions button next to the Raise Hand option in the Zoom menu. The public slide deck will also be made available on our website under the Education tab. I will post the link in the chat along with a short questionnaire asking for seminar topic and speaker suggestions. Following the presentation, we invite you to raise your hand or type questions in the Q&A. In particular, we welcome questions exploring the many dimensions of impact that these ideas, technologies, and practices have on learning health systems. As a reminder, there will not be a seminar in January 2024, and we will resume the series in February. With that, I will turn it over to Dr. Tim Beebe to introduce our speaker.
Thanks, Andy. It is my distinct pleasure to introduce today's seminar speaker. Thank you to everybody who's joined online here today. Dr. Erin Holve. She currently serves, she's had a number of very highly impactful leadership roles. She currently serves as Chief Officer for Research Infrastructure and Innovation at the Patient-Centered Outcomes Research Institute, or PCORI. In this role, she executes strategies to advance patient-centered comparative clinical effectiveness research methods and study design, develops and leads the team that will deliver on PCORI's vision of a large, efficient, and patient-centered clinical data research infrastructure, and leads strategies to advance training and knowledge for patient-centered outcomes research. Previously, she was Director of the Healthcare Reform and Innovation Administration within DC Medicaid, where she was responsible for creating, implementing, and testing new delivery system and payment models with the goal of improving care, outcomes, health equity, and value. Dr. Holve also chaired the DC Health Information Exchange Policy Board and the district's policy and investments in digital health. She has more than 20 years of experience in health policy and health services research and is a widely published and cited author of reports and peer-reviewed articles on health system design, health insurance access, as well as health IT. Her presentation today is titled Building a Patient-Centered Integrated Learning Health System, Research and Resources to Accelerate LHS. And so that's perfect for her to speak to that because she's one of the primary proponents and architects of the LHS footprint in PCORI, and we're very fortunate to work with Erin on some of our own LHS work. So I will hand it over to Erin.
Thanks so much, Tim, for that kind introduction, as well as the invite to be with you all today. And as Tim said, my goal for this afternoon's talk is really to give you all a sense of some of the resources and funding opportunities that PCORI has created with the express desire to accelerate progress toward an integrated learning health system. So let's just double check. Okay, there we go. So I want to start off on a high note, and I think Tim, may have alluded to this, and there may be some other links in the talk description that speak to the number of really exciting activities underway, and actually also the footprint at the University of Minnesota with some of these programs that PCORI has been actively developing over the last several years that I think are really strong reasons for optimism related to progress on learning health systems. And so there are several core investments really that PCORI has been making that are reaching a state of maturity that are important to know about. And I wanted to ground my talk in these because hopefully it'll give you something to think about as I walk through some of the other resources and funding activities to contemplate how these types of kind of infrastructure components and funding activities really can come together in this overlapping Venn diagram in the most positive and collaborative of ways. So later in my talk, I'll discuss more about PCORnet, but I think several folks are aware of PCORI's investments in the PCORnet infrastructure, and very pleased as I'll discuss today, and perhaps others on the call, including Genevieve, can describe some of the potential opportunities and work that may be happening quite soon at University of Minnesota with PCORnet. And then we'll also talk a bit about the Learning Health System eStar program that is funded by AHRQ and PCORI, more on sort of the people and training side of learning health systems, as well as PCORI's investments in implementation science, which have really been affected through the Health System Implementation Initiative, which was funded over the last couple years, And then really want to give a shout out to the work that's happening with our colleagues at NIH, both within the CTSI hubs, where there's substantial overlap between PCORnet, the LHS eSTAR program, and HSII, as well as the Care for Health network that is really developing to advance work in primary care. So again, I am bullish on the future of where we're headed with learning health systems. So I'm going to go through in a bit of rapid succession some of these resources and funding opportunities, as I mentioned. I will take kind of a step back in just a moment and make sure to level set with everyone about PCORI and the kind of work and research that we fund in patient-centered comparative clinical effectiveness research. But I'll also discuss, again, some of these aspects of our work in implementation science, improving methods and methodology standards, foundational expectations and engagement activities, core to PCORI's focus on patient-centeredness and working with communities, our workforce development activities, research data and technology, and last but certainly not least, some opportunities in open data and open science. So as I mentioned, I just always want to take a step back and make sure that folks are well grounded in what PCORI is and also isn't, and what PCORI does and also does not do, so that we can really scope this conversation appropriately. So I think as folks are aware, PCORI is the leading funder of comparative clinical effectiveness research in the United States. PCORI was authorized in 2010 to fund the type of studies that were designed to help people make better informed healthcare decisions. PCORI is very importantly an independent nonprofit research institute. And of course, that means PCORI is not a federal government agency. And sometimes that gets a little bit mixed up for folks. So I always like to just really underline that point. And that was by design. We have an independent board that really sets the strategic direction for the organization and represents the variety of different stakeholders and engaged partners that are so important to this work. And so, and that I think has been really critical to PCORI's success since that time. So again, as the creation and authorizing legislation indicates, PCORI's mission is really to help people make better informed healthcare decisions and improve healthcare delivery and outcomes by producing the kind of high integrity, evidence-based information that comes from research, but very importantly is explicitly guided by patients, caregivers, and the broader healthcare community. This is an engaged activity and work. And so how that translates into the criteria that we use actually even in our letter of intent process is that we directly instantiate those principles at the very sort of first step of engaging with the organization. And we feel these criteria are really important to achieve the goal of doing research differently, or PCORI, our tagline sort of being research done differently. And so that is that again, even initial letter of intent must demonstrate how patients and stakeholders or other community members are going to be engaged throughout the research process. Every project that PCORI funds must compare at least 2 health treatments, services, or practices. We'll talk in just a little bit about how there's some exceptions to this in the methodology awards. The projects must focus on questions that are really most important and can be sort of demonstrated to be most important to patients and those who are caring for them. And the projects must explicitly aim to produce evidence that can be applied in a variety of practice settings. Of course, as I've indicated, meaningful patient and stakeholder engagement is absolutely critical to this process. I'm going to talk more in a little bit about the foundational expectations, which were released last year, and really sort of take these expectations to a new level and a very explicit set of activities and commitments that investigators and their patient partners must meet. And that also includes making sure that, those who are involved do so actively and meaningfully across the entire life cycle of the project, including the development of research priorities on through to dissemination and uptake of findings. These objectives tie to PCORI's National Priorities for Health, which are the 5 ambitious long-term goals that are really interconnected and mutually reinforcing that guide everything we do at PCORI. And these are really an anchor for all the funding opportunities that we offer. And so you can see threads of these and some of the opportunities that I'll mention in just a little bit. Critical, sort of if you start at 12 o'clock on this figure, obviously the core of PCORI's mission, and this comes across in the authorizing law, is the explicit objective to move as much funding as possible into areas that can increase evidence for existing interventions and emerging innovations in health, right? Doing that comparative research on what has the greatest effectiveness for the American public. A lot of my portfolio and program, as Tim indicated, is to really enhance the infrastructure. I sort of see it as like the, the AHEAD team that, is working to really sort of lay the groundwork for the most effective and innovative patient-centered CER. And that includes, as we'll talk about, investments in data and technology, workforce development, and methodology. And then the work around advancing the science of dissemination, implementation, health communication, obviously very important to close the loop with the increase in evidence. And then 2 more kind of strategic national priorities for health. One focused very explicitly on the important goal of not just advancing, but actually truly achieving health equity within the U.S. And we know that that's a long-term and ambitious goal, but again, very important to focus on that goal of achieving health equity. And then the one that is certainly very related to our conversation today is making sure that we're continually accelerating progress towards an integrated learning health system, and really making sure that all of this work has a sort of meritorious life cycle in terms of contributing to the kind of science and techniques that are actually going to improve the healthcare system and health system in a sustainable and long-term way. So I just want to make sure that everybody has some grounding and knows about where to find more information about the types of funding opportunities that PCORI offers, because that obviously is the biggest way in which we make our impact as a funder. And so it's just useful to note that the broad pragmatic studies that PCORI funds are of 2 types. Actually, they're of 3 types. The one of them is kind of embedded elsewhere, but the 2 sort of funding levels for broad pragmatic studies are up to about $5 million. And then there's another category that has some additional requirements of $5 to $12 million. And those generally need to be aligned with the national priorities for health and some of the topic themes that the board has identified as being a priority. That's not necessarily always a requirement, and I'm happy to answer questions about that if folks have them. The methods program, which again, I'll describe in just a little bit, is a sort of smaller award generally in terms of the timeline. Those are generally 2 to 3 year programs, whereas the broad pragmatic studies program is about 5 years. And then some of these others, the science of engagement, again, very much focused on kind of the methodology and the science of improving and enhancing engagement. And then there are a series of different topical or targeted questions that are released, sometimes on varying cycles. And so, PCORI does the best job we can to announce those really early to the community, to be aware of, whether it's a focused area, an individual and intellectual developmental disability, or, sleep health, for example. And then the largest of our awards are up to about $22 million and typically about 5 years, sometimes a slightly more extended period. And those are phased awards. So there's kind of a, ramp up period where assumptions related to recruitment and the design of a study are tested, and then they're phased into the larger award. And those are now sort of offered, more regular than they had been in the past. So I want to shift a little bit with that grounding and understanding to talk about some of where we know then, if I mentioned sort of my team thinking about infrastructure is kind of the advanced team, what are some things that collectively we need to be thinking about to create the best conditions for an integrated learning health system capable of producing the highest quality, patient-centered CER? So one of the challenges, as you all know, and I'm happy to talk about this when we get to the kind of Q&A section and discussion, is that there really are multiple definitions of a learning health system. And I'm going to talk a bit about how that continues in some ways to kind of hamper the aggregation and sharing of information, as well as investment in just a bit. So we certainly have the Institute of Medicine definition, the alignment of science, informatics, incentives, and culture for continuous improvement, innovation. Again, nothing to quibble with here. It's very mom and apple pie. The challenge, again, is how do we think about really implementing and executing, or in my case, as a funder, thinking about how to make foundational investments, right, as precepts to achieve some of these goals. And I think that's where, we continue to struggle a little bit. Likewise, the sort of process cycle that Chuck Friedman and others have developed, very helpful, has some slight distinctions, but again, sort of takes these same kind of component parts and looks at ways to kind of increase the rapid cycle learning over time. AHRQ's definition emphasizes, a bit more of the sort of data and evidence generation. Though certainly their dissemination implementation programs and EPC programs, do focus on that practice piece. But again, they're all just slightly different, right? And I think that's familiar to you all. So one of the things that that our team had taken a look at then was sort of thinking about the variety of ways that are sort of just different enough that they can sometimes impede a shared conversation about continuous learning and learning health systems. And then also align how these definitions differ with respect to the type of dedicated resources and infrastructure that a funder such as PCORI might need to be thinking about in terms of, again, creating this sort of foundational set of expectations for how this work would be conducted. So, we obviously have sort of a general commitment, right, a mission level commitment to being a learning health system. And, generally speaking, right, there are sort of foundational commitments you can see across all of these in IT and data, as well as workforce. Those can vary. Some folks talk about this as being a learning system approach. Some talk about it as a model. Some folks say they're actually a learning health organization. Some disciplines or patient populations or patient groups talk about themselves functioning as a body, as an integrated learning system. There's the concept, obviously, of having a national learning system and how that would relate to surveillance and other types of activities. And then again, what we consider a bit of the gold standard, which is how to get to a patient-centered learning health system, which would probably entail all of these component parts, from organizational models, integrated system design, explicit programs of research, and again, would require even more kind of consistent investment, right? I'll also just sort of flag, and folks can come back to this, I won't spend too much time talking about it, that even when you get into some of the most thoughtful definitions of what is involved in sort of infrastructure for learning health systems, you can really see some important, I think, differences in language, as well as the concepts that are included within each of the operational definitions of learning health system infrastructure. And again, this is, I think, more of a subject for discussion with the group about how we, again, if you put yourself in my shoes as a funder, right, how do you start to think about how you kind of tackle and create the logic model, right, that helps you figure out where you should actually invest to try and, again, create more sustained support for learning health systems. And then just for awareness, and we're still working on a publication to talk about learning health system data services convening in 2023. But one of the things we're acutely aware of, in part due to the funding and investments in PCORnet, is just how many different sort of fractionated communities there are with different data and knowledge infrastructure, and how much it would really be helpful to start to bring them together, at least to a place where some of these different groups can actually, communicate more effectively with one another about what's working at a range of different sort of local, regional, national uses of health data for these learning health system purposes. And so this is work that's in progress, but, just wanted to make folks aware of it because I think there's some really great conversations going on here that also align with some of the competencies work, for example, that Chuck and others are doing at Michigan. So I'll move quickly through some of these resources because I want to save plenty of time for our discussion. And Tim can guide me if we need to sort of move more swiftly into that portion of the discussion. But I hope it's going to be useful to share some resources with all of you that you can go back and take a look at if some of these maybe are new to you. So as I mentioned earlier, about 6 months or so ago, PCORI released this sort of updated rubric, what used to be called the rubric for patient partnership. And these are now expectations that PCORI has built into the funding process, into PCORI funding announcements. And so every investigator who applies to PCORI now will be required to demonstrate how their project is going to address these foundational expectations. Now, some of them can be addressed more fully in kind of the milestones. They don't all have to be addressed in an extremely granular way necessarily, and certainly not right now within an application. But it is important to really keep these in mind to sort of design for success. So the first is, diversity and representation of key patient groups and partners in the research study. The second is that those folks will have early and ongoing engagement in the research project. The third is that individuals participating in the project are demonstrating the budget to have dedicated funding for their engagement and partner compensation to be true members of the team, just as, another co-I, for example, would be involved. That there's a demonstrated effort to build capacity for those patient partners to really work and be part of the team, right? So that's not an assumption. It's something that investigators must demonstrate, as well as meaningful inclusion of partners in the decision-making for the project and a process for ongoing review and assessment of engagement. So again, just important to understand these foundational expectations. There was really a substantial effort, thoughtful effort dedicated to identifying these. And so it's worth taking a closer look at how to do them well. So again, continuing with this kind of landscape of some of the resources that PCORI has provided, and you can see University of Minnesota listed here with the LHS eStar of the North, or LEARN. And so this is the P30 program that PCORI funds in partnership with the Agency for Healthcare Research and Quality to develop new models of scientist training and learning health system research. And I think you can see that across 16 programs, there really is a national reach to these efforts. And we're very excited trying to see some of the first reports of a range of different projects that some of these learning health system scientists are tackling. I think we're just going to learn a ton from the experience and the embedded research that these programs and their trainees conduct. The methods portfolio is a resource that everyone should know about, as I mentioned, the funding opportunity, but also to take a look at some of the findings that have come out of this work. PCORI, up to this point, as of October, has funded about 166 projects in the methods portfolio through 2024. Really an amazing breadth of work, generating more than 600 peer-reviewed publications in areas ranging from really, I think, sort of seminal and important funded research and patient-reported outcomes through to sort of the majority of our portfolio now, which is really focused in artificial intelligence and machine learning applications, which is a fascinating sort of spot for me to take a look at, because in the AI and ML projects, what I'm observing is really a convergence of implementation and applications within health systems and methodology. And so I actually think that we're seeing a lot more learning health system projects and programs come in through the AI and ML theme to the methods awards. So here's just sort of the basics and the areas of focus currently for the program. We have, PCORI is fairly unique in having this focus on methodology. So you can see there's, sort of sustained interest in methods to improve study design and support data research networks. I mentioned the AI and machine learning focus, which also I should note includes an increasing emphasis on questions like how will digital health technologies be used to take a look at outcome measures of importance to patients. But I would also draw folks' attention to the ethical and human subjects protections component of the methods portfolio. It's a bit different area of focus, and we don't necessarily receive as many applications to this very important area. So I always like to highlight it for audiences and encourage applications to that theme of the methods awards. Just want to make folks aware of PCORI's really fantastic methodology committee. And we actually just concluded a call for new applicants to join the methodology committee. And so about half of this group will be refreshed starting in July of this year. But really, fantastic leaders in the field, the many fields, who are making great contributions to PCORI and also can serve as a resource. And we try to hold convenings and symposia on various topics. So if you have topics you think the methodology committee should look at, please let me know. The methodology committee's primary responsibility, however, is to manage the development of standards for patient-centered CER. And so I just wanted to give you kind of a quick highlight and reference for these. One of the most important things that creates an opportunity for feedback from the community, likely in the next couple of months, is that the methodology committee is actually undertaking the first ever kind of look at the standards as a whole. So they've been developed sort of sequentially over the last 10, 12 years. And now the methodology committee is taking a big step back to look at the standards and refresh them to make sure they really are responsive to the current needs of the field. So there will be calls for comment and opportunities to participate in this process that are forthcoming, and certainly want to make sure folks are aware of that. There is also an important effort that PCORI has undertaken with a policy for data management and data sharing. And so this includes investments in a repository that is held at ICPSR at the University of Michigan called the Patient-Centered Outcomes Data Repository, or PCORDER. And really, PCORDER is just kind of starting to hit its stride. Actually, even as of the last time I put these slides together, and realized I did not catch that there was an update here when putting slides together for today. But now there are about 14 CER studies that are available and are really, I think, becoming an important resource for folks to think about, including potentially for dissertation awards as well. So this is a little bit more about PCORDER, which was created to really instantiate the policy and provide an opportunity for PCORI-funded researchers to have a very direct and responsive repository to hold data on patient-centered CER for the express purposes of facilitating reproduction of analyses and allowing other investigators to build on study findings and integrating data from multiple studies to generate new evidence. And as I mentioned, I think we're going to move from about 14 studies that are deposited now to, in the next 2 years, having at 30 or 40. And again, interested investigators can submit requests to access the de-identified data from these projects and conduct analyses. And right now, we're trying to see more of an aggregation of those early studies, focus more on lower back pain, stroke, cardiovascular health, and mental health. But I think, in the next year or so, this is really going to be a tremendous resource. And you can follow the link that's provided here on the left to find out more information about requesting access to PCORDER resources. I mentioned the Health System Implementation Initiative, and again, there's a lot of text on the slide, so mostly for your awareness. But the whole concept is that, the HSII is sort of a standing infrastructure with health systems, with delivery systems, to think about some common areas of focus and work, in implementation science, and so, or really implementation projects. And so there were 2 calls for proposals that happened, more recently. And we're going to start seeing a number of those projects move out, particularly focused on intensive lifestyle treatment for weight loss, as well as antibiotic stewardship. And so I think there's going to be some really interesting findings that come out of the variety of different approaches that institutions and systems are taking to disseminate and really effectively implement findings from these PCORI awards. So I mentioned that I would talk about PCORnet for just a little bit to make sure folks are all aware. So one of the things I always like to emphasize about PCORnet is that it really was explicitly designed for the research community, to be open to the research community, once it was mature, to support national scale studies that are designed to help people make better informed decisions. And it also has the benefit of really having this standing infrastructure that embeds patient partnership and community engagement in all aspects of the network, right? So it's sort of living that engagement principle within learning health systems, and that it, uses electronic health data to enhance a broader sort of national capacity to conduct health research with real world data. And then build the component parts, right? Like phenotypes, other sort of tooling, to really reuse and redo, the kinds of sort of, more rote research processes, at a variety of different scales across the network. And it's investing again, sort of at all of those levels, at the local level of clinics and sites, to sort of the regional components of the network, as well as the national level research that's conducted. And so it really is sort of that, idea of continuing to invest and maintain connections to data scientists and local clinical leaders at all of those levels. And importantly, there's one point of entry for PCORnet. So sometimes folks say to me, but I just can't figure out how to access or use or connect with people. And I always say, well, that shouldn't be the case, because if you go to PCORnet.org, /front door, just to, read the URL, there's an opportunity, like pretty much front and center on the website, to request more information. And, everybody should get a rapid response to those types of questions to the front door. And if you don't, please let me know. But basically, this slide is just intended to demonstrate that as of now, a mature infrastructure, PCORnet has been used for hundreds of studies, now actually closer to 50 national scale PCORnet studies, which have all the sort of most desired features of those types of national scale patient and partner engaged studies. The network, as I'll talk about in a moment, includes, more than 47 million patients receiving care in any given year, more than 13,000 sites of care, and just a high level of demonstrated productivity. So you don't have to take my word for it. There are lots of publications. And with the recent expansion of the PCORnet sites, and obviously, Minnesota, we're excited that University of Minnesota is, a new site coming in. There are, there's really just a breadth of participation across the country, and you can sort of get a sense of some of the demographics. There's also an opportunity to really, look at and connect more of this data at the query level to social determinants of health as well. And there's some strategies for doing that that I think are very promising moving forward. Just to give you a sense, as of August 2024, which institutions are involved and connected, and their patient populations are connected, you have this slide as a resource. And then again, don't take my word for it. I am a big proponent of showing with data rather than telling people what the capabilities of the network are. And so these are a couple of query reports that have been generated from across the network that are really intended to excite investigators' imagination about the kinds of studies they could design with the breadth and reach of a network of this type. And that's important because I'm also a big proponent of, big, hairy, audacious questions, right? There's the idea of big, hairy, audacious goals, but in research, I think we have to think about big, hairy, audacious questions. And there are a couple of reports that were released in the last year related to two areas of importance to PCORI and PCORI's 2019 authorizing law, which directed PCORI to have a real focus in our research and our funded research on accelerating opportunities to really study and improve the lives of individuals with intellectual and developmental disabilities, and to prevent maternal morbidity and mortality. And so these are examples of the types of really kind of big, hairy, audacious questions that the experts who are assembled to really think about the current capabilities with PCORnet and the data could be answered actually using this type of infrastructure, right? So a good example is really thinking about clinic-based peer support versus community-based peer support for individuals with IDD with respect to a number of different outcomes, right? Health-related quality of life, self-reported connection to community resources and overall well-being, for maternal morbidity and mortality, looking at risk-based assessment models for the quality and content of prenatal and postpartum care visits relative to current recommendations. They're really important, thoughtful questions that without a substantial standing infrastructure and national level perspective on some of these issues, it's much tougher to get the kinds of evidence that's needed to really, inform patients and providers and caregivers about the best options for them. So there are also specific funding opportunities within that broad pragmatic studies category that I mentioned to use PCORnet. And so I won't go through all of these requirements, but it's worth, taking a look at, particularly now that University of Minnesota is a PCORnet site and has some of those contacts and additional resources. And then, as I mentioned to Tim a little bit earlier, very exciting news that as of today, the phase 4 awards for PCORnet for the next 4 years of infrastructure support for the network have been released. And so you can go to PCORI's website and read about them if that's of interest. But I also wanted to highlight that, because the focus of this next sort of 4 years of funding through the end of 2028 for PCORnet is designed to really sort of speed and expand access to use of the network for conducting research, particularly doing these large national scale studies. There's a lot of emphasis on creating more resources within the CRNs for research readiness, both to make sure that the data is available with insights for particular questions, but also to help sort of think about new novel strategies to improve and sustain recruitment, in a variety of different types of studies. So you can just see kind of the direction of those investments. And then, of course, always encourage people to sign up for the PCORnet quarterly newsletter. It's very brief, but extremely informative about funding opportunities, recently released research, et cetera, that's of strong interest. And then I'm always happy to answer questions. So I'm looking forward to the discussion, but want to thank you all again for inviting me to today's session. And, again, look forward to talking further today, but also in future. So thanks so much. Over to you, Andy and Tim.
Well, thank you all. We have about 10 minutes remaining for the Q&A. If you have questions or comments, please use the raise your hand feature. We also welcome you to type your questions into the Zoom Q&A. It looks like to start off, we have a couple questions about AI. So one person asks, AI is an enormous consumer of energy and water resources, and in some ways centralizes control and can be problematic as regards to bias. How is this being balanced with the aim of equity, especially in a resource-limited environment where AI can only be fed by data of those receiving services, even as many do not have access to services?
Sorry, for some reason my menu keeps disappearing on me. It's a great question, and obviously, AI holds tremendous potential, but all of the concerns and issues that are addressed in this question are issues that PCORI is taking a very, very close look at. Most of our investments, as I mentioned, to date, in fact, all of our investments to date using artificial intelligence are in the methodology portfolio. And that's precisely right to get a handle on at least some dimensions of the question that was raised, whether it's bias, whether it's sort of comparative performance and relative juice to squeeze, right, of the resources that are used to generate that computing power. We need to know as we talk about sort of fitness for purpose of data and data quality, we need to know fitness for purpose of the use of AI as a set of tools. And again, some of those are actually not so different from lots of different machine learning or NLP tools that we've been using in the past, and others have more resource constraints. So I would just say that PCORI is taking a very close look at all of those considerations and proceeding, I think, pretty judiciously. While again, acknowledging that, we have to understand the methods to really, make sense of what the opportunity is.
All right, and then it looks like we have another question on AI. So someone asked, can you speak more to the AI focus in patient engagement requirement and their confluence? On the surface, they could be seen as pulling in different directions.
So maybe I can ask for clarification of the questioner, because there actually is not an AI component to patient engagement.
Mary, do you want to follow up with a question or a clarification?
Okay, it looks like she'll follow up in the chat.
Okay, sounds great. Thanks, Mary. And now I can see the chat, so that's great.
Maybe while she is following up, it looks like we have another question from someone that says, thanks for the great talk. Do you have examples of what gets implemented in a learning health system? For example, does one RCT meet the criteria of implementation in an LHS? And then they shared an example of one such RCT.
Yeah, I will take a closer look at the RCT, Caroline, that you've provided. I haven't had a chance to click through the link yet. I think, the first thing I would note is that thinking of sort of the standards for pragmatism, right? So such as the PCORI, certainly, taking a more pragmatic approach in the design of a trial in particular, is going to be critical. Again, I think, as I indicated in the presentation with the table, right, we still have this challenge of just using language that's kind of all over the place, right? So even in your question, one thing, that struck me as interesting, right, is are we talking about, a learning health system, right, as an organization, or, the use of a learning health system approach in a study? And I run across this issue all the time where, like, it might not be that the institution somebody is located at that is attempting to do to accelerate learning, right? Or a set of institutions sees themselves as a learning health system, but they are trying to do work. It's the verb versus noun distinction. And so I think, we all need to just sort of chew on some of those issues and consider, again, whether we're talking about using learning health system, learning health system approaches as a verb, or if we're talking about, organizations, because each of them just have different considerations with respect to then implementing study designs, in that context. So, so I don't know if I've entirely answered your question, but I do think that looking at elements of pragmatism is a good first step. And then for my money, and particularly one of the things I would like to see happen, you know, more with the use of infrastructure like PCORnet, is to really start to see us bridge that divide with the type of observational research that establishes the better sort of pragmatic foundations and conditions that are valuable for comparison, and then to do trials in those spaces as opposed to, you know, say chasing a set of, you know, comparators maybe that aren't actually truly at equipoise. I think we've all seen instances of trials that do that. And so I'd like to see us, you know, just spend our money a bit more wisely in that regard by using some of the observational research to kind of accelerate in that model. Oh, thanks, Carolyn.
Tim, do you have something you'd like to add?
Yeah, just following up on that, Erin. I mean, so I think one of the huge challenges that we have is, you know, just describing what this is, right? And as we start talking to donors and legislators about this, you know, what is our elevator speech? You know, again, you know, like I appreciate the noun versus the verb, but, you know, just how do you articulate this? You know, it's a different way of doing things, right? It's more endogenous and embedded rather than exogenous. And it's not the study of healthcare delivery, it's within. But we were just struggling with that, you know. So learning health systems as a term, you know, I think Chuck Friedman said you ask 10 people what a learning health system is and you get 11 answers. So how do you message this? You know, like when you're talking to, I don't know if you know, like a board or something and your investment in learning health system, like, you know, what is the best way to articulate what this is and what its principal benefit is, right? We're struggling with that internally because it's not manifest in the term, you know. Some people think it's all education. I don't know. We're just really struggling with that. I mean, our approach has been talking about like what we do as opposed to what it is, you know. Um, but I just, you know, have you thought about that within PCORI or in the circles that you run in, how to, you know, in a pithy and informative and exciting way, characterize this?
So we got pithy, informative, and exciting, right? That sounds
Yep,
like
they have to be all three, Erin. Otherwise, I don't want to hear it.
So it's a great question. And yes, you know, I think everyone, you know, as you indicated, talking with Chuck, I think all of us who have a strong kind of personal connection and commitment to advancing the concept of learning health systems are struggling a bit with this. What I can say, and this harkens back to my work in DC, you know, in Medicaid with HIE, is that like a lot of things, when systems work and demonstrate they add value, I think people immediately get it, right? So I started in, you know, from a career perspective, I don't know about the elevator pitch. We'll get back to pithy and exciting words in a moment. But I do think that when you show people examples of what's working as a system where you took something in sort of a pilot mode and then scaled it, right, and actually made a lot more people's lives better or more informed. They felt the health system was less opaque. They could navigate it better, right? All of those kinds of things. They get it, right? I think we've all seen examples of that. And I think the challenge is how do you put those examples into words, right? You know, because yeah, I think we've all seen it, right? Where you show somebody sort of a process and change. Generally, it's the combination of the implementation of a resource, whether it's a training tool, whether it's, you know, a new way of presenting information through a portal, et cetera. And then you show the corresponding, you can show pretty strong causality, right? Changing response and behavior, and everyone's eyes light up and they say, that's really cool, right? And that's what we need to figure out how to translate into, you know, that sort of pithy description. But like I said, I mean, you know, one of the reasons that I moved sort of from research to Medicaid and practice for a time was because I really felt like I needed to put my money where my mouth was. I needed to see how these concepts came together. And what I can say that I've brought back now to the research community is that when you show people something that works, when you show them something that truly is informative, you know, that informs care and decision making, they immediately get it. And so I think we do need to do more showing rather than telling. How to do that in an elevator is a bit of another issue. I did see a couple questions in the chat, Andy, if you don't mind. So I think Mary clarified not that AI is used in patient engagement, but both AI and patient engagement foci. And I would just say, and Mary, I'm happy if you want to pop on to talk about this a little bit more, but I don't think it's an either or. I mean, particularly from a research perspective, I would argue strongly that, you know, particularly as I mentioned, the focus on funding for advancing and understanding methods, you know, work using AI is really critical for us to understand as a community. And so I do think that investment in those areas and understanding the difference between, you know, AI as a useful tool and AI as snake oil is really critical. And then in fact, having patients engaged in any projects that use AI. And I should say that the very engaged patient partners in PCORnet are fascinated and extremely interested in effective uses of AI. So at least from the patient partners I talk with, they are ready to use it and want to figure out how to make the best use of it. And I think, you know, collectively as a research community, we have to figure out how to rise to that challenge, given the corresponding concerns that are absolutely important to address, you know, in concert. Carolyn, you know, you asked the question about observational research, then changing practice, or then informing trials. You know, I guess I think it depends on the research question, right? There's actually some really interesting work that the CDC has been doing using PCORnet, and some of the work that they did looking at you know, populations who are vaccinated or unvaccinated, and the cardiac complications that resulted, particularly for young men of different ethnic backgrounds, you could never do as a trial, right? And so I think that the data that came out from CDC's MMWR publications using PCORnet at that large scale actually offered a very compelling argument to change practice. However, I would say from the PCORI funding perspective that the primary way we're sort of thinking about the use of observational research is to inform trials. But I certainly think both are feasible. And then Steve, I was just looking at your question, Andy. I don't know if you've had a chance to parse that one. So in a clinical trial, yeah. So that is what PCORnet actually does, is uses a common data model to, you know, sort of transform or to, you know, update the records so that they can be queried in a common way as a federated system. Patient-mediated record retrieval happens in some cases, and that is something that some of the network partners are really interested in looking at more. You know, is there a way, you know, particularly for patient-reported information, to get more of that type of information into the system? But in fact, you know, so what would happen if you were doing a prospective observational study is that sites would actually sign up and then undertake any kind of consent activities that are required for a particular study to then be able to retrieve the appropriate parts of the EHR for a research study. There are also ways, as I mentioned, with the common data model to retrieve sort of high-level query data for populations as a whole. But I think for the type of use case that you're mentioning here, record retrieval for an observational study or a prospective trial would largely happen through a process of consenting the patients to access their information via the federated system. And Steve, you can let me know if there's additional information in your question. I think we got them all, Andy. Anything you missed?
Good. Yeah, it looks like Steve said, thank you. That makes sense.
Okay. And if you have questions, I can also pop this in the chat later. I'm sharing my screen, so I don't want to give anybody motion sickness, but I can send around the link to, there's an extensive amount of information on the structure and design of the common data model, which I should note, there's a lot of multilingual sites who use both the PCORnet Common Data Model and the Odyssey model, and sometimes a host of other different models. And I really do think that's sort of the way of the future. The PCORnet Common Data Model was designed for a set of use cases and is particularly designed for prospective research and particularly doing trial recruitment. And so there are some differences in the design of the CDM, but the nice thing is, just like Odyssey, the information is really transparent on the PCORnet website, so I can make sure everybody gets that link, and you can go take a look at it yourself and let me or the folks at the front door for the coordinating center know if you have any questions.
Well, thank you, Dr. Holve, for sharing these resources. Again, in closing, please join us for our next seminar in 2025 on February 4th. That concludes our presentation. See everyone next time.